I am pleased to introduce our panelists on a panel that we've entitled, How Do We Get There From Here? Words to the Wise? And it features Alan Birch, who's a drug access facilitator at North York General Hospital, Jamie Keller, who's an assistant professor in the teaching stream at the Leslie Dan Faculty of Pharmacy at the University of Toronto, and Dr. Sandy Sedev, who's a medical oncologist working in Ottawa. So I will hand it over to them.
Hi, everybody. So I'm here as a drug access navigator. I work in oncology, and we're part of a group called ODANO, so it's the Oncology Drug Access Navigators of Ontario. And our role is to help patients access oncology agents. So that's what I do on a daily basis. So the topics I'll be covering are meaningful patient engagement to get better outcomes, taking charge over your healthcare, what we are as drug access navigators, sort of what we do on a daily basis. And I'm going to be touching up a little bit on the patient treatment decision guide. If you've had a chance to see that, it's a great resource. If you have not had a chance to see it, contact someone. Louise Binder will be able to help you get a copy. But it's something that I think is it's an amazing tool, and it's applicable to everyone in healthcare. It should be used by patients, healthcare professionals, family members of patients, everyone. So about me, I am a drug access navigator. My role is to connect patients with programs and services to minimize and remove drug costs. This can range from financial assistance from drug companies, providing assistance with private insurance. So in my area, probably 40% of patients get their drugs through private insurance. We also help patients find compassionate drug access for things that are not publicly funded. And as we've heard, there's more and more drugs that are not publicly funded. So more and more patients are getting drugs through compassionate mechanisms from drug companies. So for patient engagement, this is mostly just from my experience working in the front lines in a hospital. I see patients on a daily basis. We're part of a healthcare team with nurse, physician, social workers, dietitian. So this is kind of just what I see on a regular basis. So taking charge of your healthcare, I think, is very critical. I think that anyone here is part of a patient support group is probably already way ahead of that, but the people that I see on a typical daily basis are people who have never been sick before. They've just been diagnosed with cancer for the first time. Maybe no one in their family has really been critically ill with something chronic, and it's a whole big mystery to them. It's like a black hole. What's going to happen to me? And it's a lot of fear and unknown. So I want to say that if you have more questions to your healthcare team, to your nurse, anyone like that, when you're going through treatment, just make sure you do ask those questions. They're very busy. If you've ever been to a cancer clinic, everyone's running around, but if they can't answer the question when you're asking it, just give them a few minutes and they will try to answer it. Like the nurses that I've ever seen and worked with are all so dedicated to their patients. So if you do have questions, you want to sit down and talk further, you have a concern the nurse can't help with, they can probably find you someone who can, like maybe it's a social worker issue or someone else within the hospital, but there's a lot of different resources out there for patients to take advantage of. So just make sure you ask and don't feel intimidated by these people. There's a lot of resources like patient support groups. There's seminars and classes within hospitals, videos online. There's a lot of things that are available to patients. It's just finding them. And if they're not used, they do go away. So if there's a program within a hospital and no one enrolls with it, it's not that the hospital is not trying, it's just that they will go away though if there isn't a user base. So like I was saying, to achieve better outcomes, I highly recommend the Patient Treatment Decision Guide. It was led by Health Canada in partnership with Linda Wilhelm, the Canadian Arthritis Patient Alliance, and of course Louise Binder from, she's a famous patient policy consultant. Infamous. So I got my hands on it first about a year ago, and I've shown it to people in healthcare that I work with, people at ODANO, drug navigators, and I find that it really helps to streamline your thinking. if you've never been sick before, or you're very intimidated by your diagnosis, you don't really know what to think. So this guide really helps streamline what can come in your future. Like, it talks about clinical trials, new lines of therapy. You might think, I'm just going to go on one drug, but there can be a drug after that. There can be no more drugs left, but there's a clinical trial. What do you tell your family? And it helps you really think about all these different questions that might be popping into your head. And it's something that you can look at regularly through your treatment process. It's not like a beginner's guide. It's something that you can look at after seeing the surgeon, after seeing your oncologist, after seeing your nurse, halfway through your treatment, a year after your treatment. It's something you can refer to regularly, and I think it's a very powerful tool.
Thank you.
So I feel that the guide creates a partnership between patients and healthcare professionals. When I showed it to healthcare workers that I work with, they all agreed that it's not just for patients. It also lets people who work with those patients in hospitals and in clinics kind of remember what the patients are going through as well. You can go through the guide as a patient at home. You can have your friends go through it. I find that every patient is so unique that you can't expect, oh, well, that person will just tell their family and they'll be fine, that they have this potentially life-threatening illness. They could give the guide to their family to go through it as well, so that if they can't open up in the complete, honest, open way about what they're going through, their friends and family can at least go through the guide and kind of understand what they are experiencing. I also find that when you go through the guide and sort of, it advances your thinking about what you're going through, that when you're actually sitting down with your healthcare professionals, you can ask sort of the next level questions. When you first meet with your oncologist, they might meet with you for, say, 45 minutes. If they spend most of that time explaining to you what cancer is, and very fundamental questions, you're not really getting a lot of you're not maximizing your time with someone who could potentially go into quite a lot of detail. This is someone who spent years and years studying this topic. So if they're going to spend, same with the nurse, same with the social worker, if they're spending a lot of their time with you, which is finite, explaining very fundamental things, you're not really getting the best out of those people. And I feel that you need to maximize your resources when you're outside the hospital. And the guide is something that you can do at home in between your visits with your healthcare professionals, so that when you do meet with your oncologist for a follow-up and they have those 20 minutes with you, you can get really high-level questions from those people. So in my role as a drug access navigator, I provide education predominantly. Our healthcare system is heavily fragmented, which everyone is very aware of. It's different per province, it's different per hospital. Every hospital in Ontario has its own sort of policies and ways of doing things. An Ontario hospital is going to be different from a hospital in Alberta. So a patient going through the system is going to get a completely different experience depending on where they get sick, unfortunately. So at least in Ontario, with our fragmented system, I spend a lot of my time explaining to patients, okay, you have a drug plan, but your drug plan has a $1,000 maximum on it. That's not really going to go anywhere in cancer. We tell patients, everything in cancer is very expensive. And a lot of people will say to me, well, I can probably just pay for, 1 or 2 doses, right? How much is expensive? Like $200? And a lot of the oral agents are $4,000, $5,000, $6,000, $7,000 a month. And they like crumble in front of me when they hear these prices. They get sticker shock because they've been prescribed this drug that they know they need. Their insurance, which they've been paying into for years, doesn't really cover much. And they get really scared. So we want to make sure that, your insurance may not cover the drug, but I can find you some way of getting that drug covered. So we're going to ask the government to cover the drug. Okay, it's not a benefit because the government is taking longer to add drugs to their formularies. So we're going to ask the drug company for the medication. Your medication is available from the manufacturer. If you meet these criteria, you do, so you can get that medication. So that's what I do on a daily basis. We want to make sure that we connect people with the right resources and make sure that they can start their therapy. We also help with insurance. So if their insurance, say it has $1 million maximum or no maximum, there's probably a lot of forms they have to go through. They have to be connected with a patient support program because usually insurance doesn't cover 100%, it might cover 80%. 20% of a $9,000 drug is still cost prohibitive. So we still have to rely on the drug company for financial assistance. So even if you have an amazing drug plan, typically you still need some help from something because oncology it's so overwhelmingly cost prohibitive. So a little bit of an example, we do have cheaper medications in oncology. We typically use like the latest medication. The cheaper drugs are the older drugs, and they're not as effective as the one that just came out 6 months ago. And the newest one is $10,000. The older one is a few $100s, but it's not the best one. So we want to give the newest, best one. Taking time off of work is another cost impact for patients. But there are people to help. So my role, social workers, your nurse, someone is there to help you with these things. So I just want to make sure that everyone uses the resources that are available to everybody. So as stated, working together in partnership with your healthcare team, secretaries, everyone, it creates a better outcome. I want to make sure that patients don't see themselves as just being walked through this system, that it becomes more of a partnership. You don't see these people as intimidating or white coat syndrome, anything like that. Your physician is a partner with you. Your nurse is a partner with you. I can be a partner with you if you're at my hospital. Everyone is there to maximize your outcome. So I have just this is basically a very routine sort of situation that we experience as a drug navigator. So someone who's 45 years old, has stage 4 lung cancer, seen by their oncologist, is prescribed an immunotherapy. She has a drug plan, so she thinks that's great. The drug is not covered by the government, it just came out. Will her insurance cover the drug? Is prior approval needed? So what type of paperwork do we need to go through? Is there a cap on the insurance? More and more insurance companies they have caps on them of $10,000 or $25,000, which is great for chronic medications that might not be like oncology, but $10,000 doesn't go very far in cancer care. Can the patient afford the medication if their insurance says no? If the insurance says no, is the out-of-pocket cost affordable for her family? Is there an alternative therapy? How long is all of this going to take for the patient? They want to start right away. And that's before anything actually starts. There's a lot of things that have to be resolved before someone actually sits in a chair and is given their treatment. So we try to get this done as quickly as possible. Anytime I give a talk, I try to make sure everyone knows that if you're a part of the insurance provider, the government, everything has to be done as quick as possible. In my experience, we have patients not regularly, but sometimes they do pass away before they start treatment. They're just so ill by the time that they see their oncologist. So every day does make a huge difference. And if we're waiting for insurance or if we're waiting for government to approve things, something that's funded is just waiting, for example, approval from the Exceptional Access Program or their Trillium application. It can be life-threatening. So just in summary, I recommend everyone read the Patient Treatment Decision Guide, get your hands on it. It's a great resource. It's long, but it's very useful. Every piece of it is relevant at some point in a patient's treatment. It can help you reflect on your goals. What do you want out of treatment? Do you want to just forego treatment completely? It's for your friends and family. It's for everyone. There's a lot of barriers in accessing medications. I'm most aware of cost because that's what I do on a daily basis. It's a huge barrier. But there's a lot of people out there to help. There's patient support groups, there's patient agencies, there's resources in hospitals, and we need to use those as much as possible. Healthcare is more and more complicated, but an empowered patient forming a partnership with your healthcare workers, you'll get better results if you can do that. Thank you.
Okay, so I don't come from the oncology world, I actually come from the psychiatry world, and I'm a pharmacist by clinical background. Yeah, maybe my slides will move. Oh, okay. So, just a little bit about who I am. As I mentioned, I'm a licensed clinical pharmacist by background. I've been an inpatient hospital pharmacist my entire career, working in psychiatry, both at Ontario Shores Centre for Mental Health Sciences, which is the former Whitby Mental Health Centre, and most recently at CAMH, the Centre for Addiction and Mental Health in Toronto. I'm also an administrator. I'm the director of the Doctor of Pharmacy program in the Faculty of Pharmacy at the University of Toronto. So I oversee the curriculum development and design for all education for pharmacists of all disciplines across Ontario. I'm a teacher. I teach all of the neuropsychiatry courses as well as health systems and policy courses. And I consider myself actually an advocate for patients and families that are trying to navigate and live with a variety of mental health disorders. And so just as a reminder, because I think that sort of I fit between some oncology folks, and when we talk about drug pricing in oncology, you've just heard we're talking about drugs that cost thousands and thousands of dollars a month. Well, the tale's not the same in psychiatry. We're talking about drugs in some cases that cost pennies a month. And so I think that pricing can be looked at from a number of different angles, and the angle in psychiatry is a little bit different, and I think I'll help you take a look at that when we're thinking about drugs and outcomes for psychiatric patients. But as a reminder, mental illness is something that will touch all of us directly or indirectly, and more than 20% of Canadians live with a mental illness at a given time in their life. And certainly we all have contact with individuals that are currently experiencing mental illness or have had in the past or will have in the future. And I think one of the things that are really unique and it's important to understand when we're thinking about psychiatry is that it is a chronic illness. Many of these things, schizophrenia, depression, bipolar disorder. But when I ask folks about chronic illness, things that come to mind are individuals that are developing illnesses like diabetes or cardiac issues in the middle of their life. We're talking about diseases that are starting in adolescence, in childhood in some cases, that will last in many cases a lifetime, and they're actually starting at the most productive time in most individuals' life, and that's really unique. And when we're talking about medication in psychiatry, although potentially the cost of the drugs is less when you're looking at it on a monthly basis, the cost of drugs goes beyond the dollar value. And if you're starting drugs in patients that are 15 years old, what's the cost to the human being that takes that drug until they're 70 or 80 years old? And those have both direct personal costs and family costs, but they also have costs of the healthcare system, lost productivity in society and to our communities. And so I think cost is bigger than the dollar that we put on a medication. And you can see the Mental Health Commission of Canada is estimating that currently mental illness in Canada is costing us $50 billion a year. So I would argue those costs are pretty significant. And when we think about outcomes in psychiatry, what are we actually measuring to think about people with mental illness and what do positive health outcomes look like? Well, we can think about symptom resolution. We do measure that. We measure response to treatment, be it medication or psychotherapy in most cases. And we use rating scales. We use Hamilton scores to measure changes in depression symptoms. We use a Montgomery-Åsberg scale to measure depression as well, or an anxiety scale, or a scale to measure schizophrenia symptoms. But we also measure things like community integration or reintegration. We're in a movement now where we're trying to get folks with mental illness out of hospitals and back into the communities that they come from. We measure things like readmission to hospital, which is not unique to psychiatry, relapse, how long people stay in the community before coming back. We measure length of stay in hospitals, how long are patients staying in acute mental health inpatient units, and how quickly can we get them back to the community. We look at whether we can get people back to baseline function. And that's function that is important to them, whether that's occupational function, social function, function within a relationship or a family. So function actually is quite broadly defined in mental health. Things like medication adherence and how can we help folks take these medications on a daily basis. And so these are common outcome measures. But what's interesting is that these measures, when you look at them, aren't so different than other disorders. But I challenge us to think about, should they be? Because things like reduced readmission and reintegration to the community makes a pretty broad assumption that patients want to go back to the community. And many patients do. But I have a number of patients that actually say things like, but CAMH is my home. I've been a patient here for 20 years. I actually don't know anything else. And so I think we make a lot of assumptions about community living and what it means to many individuals. But it's not always the same for folks that are reintegrating into a community with a chronic mental illness and the amount of stigma that we still have for many of these disorders. We also look at length of stay. It's a big driver, of course we must be doing well, you must be better as a patient if we get you out in 10 days or less. Our drugs take longer than that in psychiatry to work. We're asking psychiatrists to discharge patients before we have any idea if the patients are responding to medications that take, in some cases, 6 weeks to have an effect. So that's an acute care measure for an acute inpatient psychiatric unit that's not the same as every other unit, like general medicine or the ER or somebody that's just had some fancy procedure in cardiology that may actually allow somebody to get out faster. And so I challenge us to start to think about who defines these health outcome measures. So although I'm a clinical pharmacist, I should also disclose my research, I'm actually a critical social science researcher, and so I see the world through critical social sciences and who gets to make the decisions around outcomes. And so what I would suggest we start to think about in psychiatry, and we're moving in this direction as with everywhere else, is this notion of client-centered health outcomes, and what is the important goals or health measures that are relevant to the individual patients that we see, and how do you start to negotiate meaning for people, not broad populations. And certainly we use the term client-centered a lot. We throw it around. It's the new trend. I study discourse, so I'm interested in the patient safety and the patient-centered discourse. But to have a discourse in a language and actually live it are not the same thing. And so I really do start to challenge us to think about how do you make meaning out of these kinds of things in psychiatry. And so working with patients and families to determine what the goals of treatment are for individual patients, and it might be community reintegration, or it might be to leave the hospital for 2 weeks out of this year with the rest of the time being an inpatient, and maybe that's okay. It might mean that they get to choose the drug that has the side effect profile that they think they can tolerate, even though it might not be the gold standard or what we as a treatment team would pick, and maybe that's okay as well. And trying to work with individuals to figure out how to be able to meet the outcomes of health and how health is defined by the individual in front of us. And I think one of the ways that we need to do this and to make it more effective is to start to leverage the disciplines involved in healthcare and to start to use all of them to their maximal skill set and start to think about who can provide what kind of care or monitoring or follow-up to patients. And I think there are a number of challenges, and I don't know that these are all unique to psychiatry, but certainly these are the challenges that I face in the patients and in the teams that I work within. Professional hierarchies are real. But what I mean by that in healthcare is that there are a set of rules and expectations depending on the professional label that you wear, that pharmacists follow the orders of doctors and we give what's prescribed. That's not actually how we're trained, and in some cases, the right thing to do is to ask the prescriber, is this really what you want, or can we consider another option? I consider myself to be an advocate for the patient, and if they don't want to take the drug that I'm handing out, can I figure out something else that might be a reasonable solution and start a conversation with a prescriber and really start to look at collaborative care and start to think about how the different drugs and the different disciplines can start to fit together. One of the big things that we see in psychiatry, I don't know that it's not different in other health areas as well, is polypharmacy. This notion of using multiple medications to treat the same condition. And that might make sense in certain disorders where we have evidence-based guidelines to say that these 3 drugs are better than any one of them. That's not the case in psychiatry, and I'm going to show you some data. And this is expensive, not only from a drug cost perspective, but to the health of the patient, usually from a side effect perspective. And I'll show you some data that's unique to psychiatry. I also think there's a lot of issues in psychiatry, and again, probably in other areas around continuity of care. We have a number of patients that get discharged with no access to a drug plan. And one of the biggest challenges for us is that we often discharge people to shelters in Toronto at CAMH. A shelter is not a fixed address. And so it's a very hard thing to do as a clinician to say, I need this bed for somebody who's acutely more ill. I know you don't have a home, so I'm going to discharge you to a shelter, and I know that you now can't get drug coverage, and I know that that bag of drugs for 6 days means that in 6 days this patient has no drugs, and I have no mechanism in place, and if it's an old drug, I don't even have a pharma company that can give them a compassionate supply, and I've got nothing but knowing that I'm going to see them whenever those drugs leave their bloodstream and they get sick again. And those are system-level problems, but those are what we live with on a daily basis. So starting to think about how do we actually start to do something different with these things. And I don't have great answers. I have a few suggestions. I think the other thing, and as a pharmacist I wear this hat a lot, is the patient safety issues. There are often multiple pharmacies in Ontario involved in patient care. And our privacy laws in Ontario are the strictest in the country, good, bad, or indifferent. But one of the challenges is that we don't have pharmacy systems that are integrated. So you could have 2 Shoppers Drug Marts right across the street, side by side. And those computer systems don't talk to each other. You could go to Joe's pharmacy, get a prescription, and 2 minutes later come to my pharmacy, and I won't know that you ever saw Joe because we're not allowed to connect those systems. That is different than in BC and in Alberta, for example, where I can see every pharmacy you've ever been to. Why does this matter? Because the more drugs patients are on, the more drug interactions they're on. And if somebody doesn't have that full list and is checking for those safety issues, patients are at risk, and not necessarily at risk of death or horrible things, but side effects that are uncomfortable that we know compromise adherence. Multiple prescribers is the norm in psychiatry. We've got general medicine folks. Sometimes we have folks that are managing other chronic conditions. We've got psychiatrists. We've got nurse practitioners. And these notes go into the hospital note abyss. They often never make it to a consolidated chart. And so those things leave gaps in being able to piece together full medication histories, for example. And again, drugs are not the be-all and end-all. They are what we have, but in psychiatry, if you look at the evidence base, psychotherapy for many things is as effective, possibly better in certain conditions. But the wait lists, the cost out of pocket, most of them aren't covered. The wait list for cognitive behavioral therapy in some of our institutions is close to a year at this point, depending on your age, the community you're from, etc. And so these things also start at a system level have impact, and they contribute to prescribing more because drugs are available and accessible. And so I just wanted to give you a little bit of data on polypharmacy in psychiatry because it is becoming the norm. Most patients are now managed on multiple medications, and that's relatively new. This is one of the biggest outpatient community studies done in psychiatry in the United States, and it was office-based patients that were being followed by psychiatrists in community settings. And it's a 10-year data where they have over 13,000 patients, and in psychiatry, 13,000 patients is massive. We're not cardiology. We're used to like studies with hundreds of patients, not thousands. So this is a pretty big one. And what they were looking at over this 10-year period was the number of medications prescribed to patients. And what they actually found was that there was an increase in the number of psychotropic medications prescribed across all years. And patients that went on 2 or more medications to treat the same disorder went from 42% of the patients in 1996 to 60% in 2005. And the patients on 3 or more medications to treat the same psychiatric indication went from 17% to 33%. That's a third of the patients on 3 drugs to manage the same condition in a 10-year period, with no new evidence to suggest that this makes sense. And so that was interesting. And what they concluded was that there have been significant increases in the number of drugs that we're using to treat patients in psychiatry. Some combinations are supported by evidence, but the reality is most of them are not. And the trends are putting patients at risk of drug interactions and side effects with really almost zero gains in clinical outcome. And I think that we have to start talking about these things because more drugs are not always better. New drugs in psychiatry are not always better. And so how do we start to actually challenge these things to optimize care? Why do we see this in psychiatry? Well, one of the challenges is that many of our patients don't get remission from the drugs that we have. And that's a huge challenge. And so we want them to get better. Everyone wants their patients to get better. And so we hope that giving more drugs will achieve that. And you can see, you can have these slides. These are the 3 landmark trials in depression, schizophrenia, and bipolar disorder. These are randomized controlled trials done by the National Institute of Mental Health. And even in these study samples that are really well controlled, you can see huge proportions of the patients are treatment refractory to the best treatment fully covered. And I've listed a number of the reasons that we see these prescribing situations arising in psychiatry. But in close, what I want to say is that there are a number of challenges in psychiatry that aren't only related to the specific individual costs of drugs, although we are seeing the trend that drugs are getting more expensive. And in psychiatry, that doesn't mean they're clinically superior. And I thought that was interesting from the talk ahead of that went before me, in that a lot of the newer drugs in oncology are better. One of the best drugs we have in psychiatry is clozapine, and it's like the oldest. It was synthesized in the 1960s, 1959. So in psychiatry, new is not always better. In fact, most of the time it's the same, and we call them Me Too drugs. And that's not to pick on pharma. That's not to say that these drugs don't have a role. They have different side effect profiles. They increase the toolkit. But it means that more or new isn't necessarily better, and if a patient can't afford it or it's not covered, we can go to the old drugs and still get really good outcomes. And again, just keeping those things in mind are really, really important. I think it's also important to realize that pharma does what they can, and they've had downsizing in some of their brain science divisions, and some of them have closed, but it's really hard to discover new drugs in psychiatry. We don't have models in psychiatry like we do for other diseases. Nothing else walks and talks, right? Only us. And you can't test drugs in humans. So a dog heart might be similar to the heart of a human, and we might be able to get really good data and know that the drugs are going to do the same things in people. In psychiatry, we actually understand the diseases based on what we know about the drugs. It's backwards. And we know that the drugs don't treat all of the people, and so we know that we don't understand the diseases that well. And so pharma has a lot of work to do. It's very expensive work. These patients are really difficult to study. These diseases are complicated because the brain is complicated. And so unfortunately, we don't have great new drugs right now, and that's one of the main challenges, and that's why we're starting to see so much polypharmacy. So what do I think we can do about it to close? Well, I wish I had all of the answers, but I do think collaboration is one way to start to look at it and start to value the skill sets and the input of different healthcare providers to optimize outcomes, to work with the patients to define what outcomes they're trying to achieve and what's meaningful to them and what does well mean to this person. It might not be what I think well is. Trying to enhance continuity of care through communication, sharing drug records, encouraging patients and families to make sure that there's a list of drugs that one pharmacist has or one physician has, that we know what everybody's on, including over-the-counter and potentially illicit substances. And for me as a pharmacist, I think there's a number of things pharmacists can do and that we try to do. I think pharmacists actually have a really solid skill set and they can advocate for patients, and they need to start to challenge prescribers politely and professionally, but if there are other options or if there's an avenue for conversation that might improve an outcome for a patient, to do that, and to challenge polypharmacy that's not evidence-based. If there's no evidence to support it and the patient might be at risk, then there's no reason to prescribe multiple medications for the same disorder. And starting to challenge those things and say that it's not okay to give more drugs to people if you can't get an objective change in clinical outcome. And again, trying to help folks navigate the system, trying to work with drug companies if folks are going to shelters. Can we get a less expensive drug that the hospital's willing to pay for until we get them a home? And we do that at CAMH sometimes. But we have to start to think a bit differently to make sure that the patients get what they need, because the haloperidol that we send from the hospital at pennies a day is less than the readmission of that patient back into the hospital because we've let them decompensate. And so I think trying to think about not individual rules, but the bigger picture can help us improve our care. And with that, I will pass it on.
Is this working? Yeah, thank you. I'm a Mac, so sorry, I'll be trying to stand behind my transparent podium here while using my Mac. The last two talks really, I learned a lot from those. I learned that mental health is very important to all of us, but our mental health as clinicians in oncology and medicine is being gravely affected by Alan's demonstrated access problems actually in our field. And this is not a minor issue. You know, in our patients now, delay in access to therapies because of funding is causing severe stress, anxiety, anger, communication barriers with the healthcare team, 2 or 3 visits over a month or 2 just to get the funding while their health deteriorates. And about 50% of our clinicians have severe caregiver burnout in the oncology field, I mean doctors and nurses. So this is really affecting us. Our pay has gone down because we spend more time filling out paperwork for which we're not remunerated. We can't see as many patients in the day. Wait times are going up. These are having actually a lot of indirect impacts on us. So my theme was kind of piles of progress, lots of progress in oncology, lots of new things happening, very exciting, but also lots of bureaucratic impact and delays because of cost. I would argue cancer is different. When I talk to rheumatologists or GI docs, with monoclonal high-tech therapies, they've made major advances, and they use a lot of these drugs, very expensive drugs, for years and years, lifelong therapy, a lot of money over the lifetime of the patient. But they usually have 1 or 2 drugs each per discipline. And we have maybe 30 high-tech new things coming out, a year in oncology, and we're really faced with this tsunami of drugs we have to keep up with. And the need for the patients is extremely urgent. These are diseases that threaten life and limb function, mortality very imminently. So I think I argue that the decisions about pricing and access are even perhaps the most urgent. And oncology has often set kind of the standard of how we approve new things, and later on, other diseases in internal medicine especially have followed suit in terms of approval pathways. So what does it imply with this urgency issue? Well, we have this kind of time bomb with our patients. They need therapy right away. We have issues now where drug access and reimbursement usually lags behind America by 1 or 2 years now. When I came out of PMH in '91, we were generally ahead of America. I actually went to the States to practice upstate New York when I first came out. There was no community oncology really in Ontario because the hospitals couldn't afford the CAT scans, never mind the drugs back then. We had anti-nauseants the year before. People were vomiting for an extra year in the States, more than we were in Canada with chemotherapy because we had a drug called Zofran. But now the rest of the world, and America is not always the standard bearer. I mean, we're behind them, but we're also behind all of the European socialized medicine environments where their costs actually per capita are less than ours. We're the second most expensive system in the Western world, even though we're not performing as well. Most of those places now have adapted to the urgency by adapting and funding and approving drugs based upon endpoints such as progression-free survival, response rates, even phase 2 data. When the gold standard in all of medicine is always, level 1 evidence, phase 3 trials, overall survival. And as a student, I learned, the most important thing is how long do you live? What's your quality of life? If the scans look prettier for a few months, that's called progression-free survival, maybe it's not so important. But now we have drugs that are profoundly better for progression-free survival. If you keep the disease from progressing that much longer, that's a big delay in the patients in their suffering. That's a big delay for them requiring nastier, older drugs like chemotherapy. So it has a major impact now the FDA has recognized and we have not. We also have questions of efficiency. How do we integrate our process? This is my overarching theme for today, is how do we coordinate our systems? We have very good systems in Canada from a regulatory and evidence-based kind of perspective, but they're extremely slow and they're getting worse and worse every year. I've heard PMH oncologists brag international meetings, how rigorous our processes are. But while they were bragging, I illustrated to actually a European person touring Canada, yes, but our website from CCO has guidelines for lung cancer that are 6 years out of date. So, we have to keep up with the rapid changing environment. But we have to also have fiscal responsibility built into this. We're all taxpayers. We only really have one taxpayer end of the day. We have to make sure we're constantly reevaluating the evidence as we're faced with it to make sure we're getting value for our therapies. And the big problem is we have so many silos now, and the silos have become a problem. We have Health Canada. Health Canada approves almost every drug in oncology brought to it. Companies aren't going to bring a drug without robust evidence, and it's already often gone through FDA and Japan and Europe by the time it gets to us. CADTH and PCODER then say, well, the evidence is sound. We think we should use this drug mostly, but it's not economical, and it takes another year or two for other funding bodies to negotiate price and access. I think you may have heard about that this morning. CAPCA is a new organization. It's kind of a gang of all the provincial cancer agencies, now adding an extra layer, saying, well, this drug is now valuable, but let's not pay for that yet. There's one or two coming down the pipeline the next year. Let's wait for them, then we'll pick the one that's the cheapest or the best and negotiate a better price. And our patients are literally getting sick and dying waiting for this. The provinces have varying processes. The clinicians have their own silos. We have different oncologists, we have lab clinicians and lab testers. Our lab testing now is built into the process of how we approve drugs. We know there are very many targeted fancy drugs now that work really well if you have a certain mutation in the cancer or a certain protein expression in the cancer. Those tests might cost $200, $500 to do, and those access to those relatively cheap tests are now causing a barrier to access because the hospitals can't afford the $200 test to get a $10,000 a month drug funded. There was one test that even though the company was helping to pay for it, the province eventually paid for it, the labs couldn't handle the $45 packaging shipping costs. And that was causing delays until the company finally said, we'll pay each hospital $45 a sample just to get the samples going. These are all the silos that we're facing. And the poor patients kind of get shoved aside altogether. So we're at a fork in the road now. We have a lot of things ahead of us. We have an exciting road ahead of us. It's probably the most exciting time to be an oncologist, but how do we get there? So I think the key is coordination of our efforts. We have to work in parallel at the same time in our various silos, not one after the other after the other. We have to have performance standards for governments. Governments like that terminology. I think we've been more effective advocating for change when we say, look, the system is broken. Not I want this drug from that company or that drug from that, but the system has to be fixed. When I actually talked to a deputy minister in Ontario once and said that, it's taking about 2 years after Health Canada approval to get provincial decisions on funding. He didn't actually believe me. We rolled out the spreadsheets and showed it was about 2 years. That has to be fixed. We have to have patient-centric approaches. We have to have faster reviews and decisions, not that kind of drag on. We can't keep adding layers. And we have to avoid perhaps outmoded and less effective therapies in our processes. The lab testing I talked about, molecular profiling is integral. Some of these fancier tests now can cost up to $5,000. One of them, called Oncotype DX, is a genomic profile for early-stage breast cancer. I helped to get that funded January 2010, front page National Globe in Ontario. By doing it to everyone in the province to test their cancers to see who really needs preventive chemo and who doesn't, we save about $30 million net a year because of avoidance of chemotherapy costs. What about equity? We still have this terrible landscape of every province and territory having their own little silos and approval mechanisms, different levels of efficiency and speed. PEI historically has been, frankly, a basket case in oncology to get access to drugs. There are countries like Turkey and Chile that had faster access to MRIs and PET scans often than we do in some of our eastern provinces. That needs to be fixed. We're a small country. We don't really have an excuse not to have a national cancer strategy. I think we're the only Western country without one. And we have to have principles behind what we do. There's no reason why we should have a different process for oral drugs and IV drugs. It just boggles the mind. André Picard had an article on that in the Globe. Nothing's happened. The governments met in Ontario. They agreed it shouldn't be that way, but it is that way to this day. 2 years later, nothing has changed. If you have an oral drug, it can take 2 or 3 months to get a decision. For an IV drug, I can enter it in my computer, pops up a website from Cancer Care Ontario, I meet the criteria on the buttons, and it's funded immediately. CCO told me they could adapt that software for orals very, very quickly, but ODB said, oh no, we have our own systems. We do it this way. We have to develop our own software. It'll take a couple of years. It may launch next March for a similar kind of approach. We have to measure the fit and make sure that what we're doing is actually affecting things. We have to probably even have dynamic comparisons with our outcomes and on what we're doing with other parallel Western social medicine systems. I think it's unreasonable to compare things to the States, although it's come to a point now where, at least with Obamacare, while it still exists, a homeless man in Chicago can actually get access to oral targeted drugs, $8,000 a month for lung cancer, very quickly, within days, through Obamacare. Whereas the same person in Ontario might take a month or two of paperwork and might not, and might still have a copay they can't afford. So every piece of the puzzle, I think, should be designed to help improve the patient outcomes. We have to streamline things. I like the idea I've heard from patient groups about having silos that are around a disease scenario. A budget, perhaps, to manage this kind of patient with this kind of situation or this kind of comorbidity index. That budget to manage that patient from diagnosis, testing, lab testing, all the way through as a bundle. We have the technology for that. Metrics should be collected on timelines as well. We should actually measure government responses as a patient community. How long did it take for this drug or that drug prospectively to get approved? There was one calendar year, I think October 2015 to October 2016, when PCPA didn't approve even one single cancer drug in the whole country that year because of backlogs. And we have to build in escape mechanisms. We have pressing data that's very exciting, and if the processes we have are rigorous and take time, then we should have a back door. We should have an expert the governments have assigned to say, look, right now it's in process, but in the meantime, this expert panel will look at case by case and make a decision. And not to open the floodgates, they can say no later, but in the meantime, they've got the back door. They used to have that. And they took it away in 6 months, years ago, because the budget was exceeded and drugs were being approved quite rightly, too often. The metrics need to make sure that our new approaches are working, but we should not have to wait for all of them to achieve success. You may have heard this term, real-world evidence. What's actually happening once we have a new drug in place? How is it affecting our outcomes? We should collect that. But if it's just an extra layer we need, before we approve funding, it's just an extra delay for our patients. It should be funded and approved, maybe tentatively, while we collect real-world evidence. We have models for that, the CCO evidence-building programs, but no one wants to pay for them. If we need hard data, the government should take part, perhaps with pharma, collaboratively, to say, let's put money in to collect real-world evidence rigorously. We do this through the BC Cancer Registries. They do it in Scandinavia and Holland very, very effectively. And if things don't work out, we can reevaluate them. But we should accept as clinicians, maybe we shouldn't use a drug if it's not really panning out. Generics seem to be underutilized in healthcare, I think, across the board in Canada. Our generics, I've learned, cost double to triple on average what they cost in America. I defer to our pharmacy colleagues on that, but we have less competition in the generic market. The average, Joe on blood pressure pills and cholesterol pills is on a generic. And for most of our drugs, we're paying more than Americans for our pills. Biosimilars are kind of like newfangled things in oncology. They're biologic drugs, complex antibodies made in living cells. Big blockbusters in oncology, Herceptin, for example, Rituxan in lymphoma. They're now coming down the pipeline now with biosimilars that will be cheaper. And if they're cheaper, that money should be reinvested back into the field of innovative research and development in cancer. And I don't know much about this, but I know in terms of buying, we've had talks about national pharmacare. I'm actually attracted by the concept, if it worked properly, to negotiate as one large kind of consortium in oncology, risk-sharing agreements that work very well sometimes work well in France and Italy, and these public-private partnerships that can work collaboratively to make things happen more quickly. We really have to break down the silos, though. I think I've shown that. We have one taxpayer, the whole IV issue. Hospital clinics versus private infusion clinics. It doesn't really matter. We're having patients now that because of their private insurance policies have to go to a private clinic where they don't have expertise in oncology. They may not have a doctor even in the room getting therapies just because that's the way the funding seems to allow for them. We have to probably have dedicated budgets for testing as well as for treatments. We have a new drug funding program in Ontario. When a new drug comes, if its drug is approved, they reimburse every hospital for the drug if we use it as per policy. And that makes sense. That came out in about 92, 93 for Taxol, the first expensive cancer drug. We have no thing like that for testing. If a molecular test costs a few $100s, why can't there be a new test funding program where the lab people just punch it in on a website and they have funding for that test to be done? We have silos between home care and inpatient care. We have the same issue. People go home and come back in because of poor transitioning to consistent quality home care. Fundings for consultations. We're having to see patients now every 2 weeks sometimes, where before they might have come every 3 months. But the funding for clinicians for complex cancer care only allows for 1 or 2 complex fee codes a year. And the rest might be $18 for a patient visit. So we're underfunding the complexity of care we're asking our clinicians to provide. The private drug plans through insurance companies now, you may have noticed this, but starting in Western Canada recently, I think Manulife and some of the insurance companies here, they're trying to integrate their drug formularies now with the PCODER and CADA processes. So if you paid your whole lifetime of premiums into drug insurance, and you need a drug urgently because the government is 2 years behind, now insurance companies will say, well, why should we spend our money duplicating the wheel, having our own review process? We'll wait for CADA and PCODER, and we'll emulate their policy. I would argue, why even pay for private insurance then? The semi-private room is worth nothing. Who cares? Just pay for your private room and don't waste your money on drug plans. We don't need drug plans for penicillin. We need them for very expensive drugs nowadays. This is an American diagram, but this is a real diagram of the complexity of healthcare in the States. When I was in the States, I came back during a recession, sold my house after 2 years at a great personal loss. Because I couldn't handle it. I thought it would be similar to Canada, relatively socialized medicine in New York with Medicare and Medicaid. The rapists and murderers from the higher risk prisons in the Adirondacks were getting uniform care that the guards couldn't get with their unions because they didn't have a good HMO or a good funding program. Small businessmen had to bankrupt themselves to get state Medicare. People who were getting Medicare treatment had to go to the dumpy hospital clinic to get treatment, whereas anyone, even a janitor at Kodak with a good HMO plan, would get Cadillac care in our private clinic in our office. That's the way it's kind of going in Canada, and I really find that upsetting. And that kind of reminder of how it was in the States really has got me kind of boiled up enough to have an interest now in advocacy. We really have to think of the patient. We look at these survival curves and data. We have to always think, if it was me or my mom, what curve would I want to be on? Which therapy is easier, reasonable? Why can't we get the same cost that Europeans are getting? So with that, I thank you for your attention, and I look forward to a good discussion.
Thank you very much for these wonderful presentations. We are actually going to inverse the order and take a couple of questions from the audience before giving the final word to our patient respondents. So if there's a couple of questions in the room.
My question is for Alan. I'm Tracy Jones from Brain Tumor Foundation of Canada, and I'm just really interested in the resource you were talking about, the Patient Treatment Decision Guide. Can you tell me, is that something that has been adopted sort of throughout the province, or is that something specific to your site? Yeah.
So the guide is still, I would say it's in a beta form still. It hasn't been finalized yet. I'm hoping that when the final version is out, and that it will be sort of universal resource available in cancer centers. We have a lot of pamphlets and things from CCO and from the Canadian Cancer Society. I hope that the guide would be just added to that and hopefully available online as well as a resource. But currently, it's still in the works.
Yes, thank you. Dave McMullen from Myeloma Canada. Dr. Sadev, you mentioned that sometimes in Europe, they get access to new drugs sooner and at lower cost than we do here. I'm just wondering, any thoughts you might have or anybody else in the room, what are they doing in Europe that we could be doing here in Canada?
I'm not fully aware. I think my colleague, actually Parneet Chima at the William Moser Center knows a lot. She had a paper at ESMO, the European conference, comparing our processes. But there, it varies by country. But the more Western, modern, countries like France, for example, once the regulatory body, their version of Health Canada, approves the drug, funding tends to follow almost automatically, like the FDA. So it's a bit faster, and plus they're much more open to these partnerships with pharma in terms of risk sharing. That if the models work out and they end up, the impact on the budget nationally is what they expect it to be, the benefit to patient outcomes is lining up with the anticipated metrics, that's fine. If they don't, there's some kind of risk sharing where there's a give back to the government from pharma companies. So that kind of model, I think, has been adopted in France. They also had a committee go through years ago called the Chirac Committee in France, where they also had before a lot of differences in access to not just drugs, but radiation and testing, all across the country. And they tightened it up. There was a real scandal, and the Chirac Committee mandated that everyone in the country should have access to the same level of care in every center, including phase 1 and 2 trials. So they did kind of clean up their act some time ago. I think Italy now actually has, even though it's an economically challenged situation, has a pretty rapid access. Germany's a mixture of public and private, but no one really tends to fall through the cracks.
Okay, so I think what you're saying for faster access at a reasonable price is simplify the process and consider risk sharing.
Yeah, I think so, and also to be somewhat reasonable in terms of looking at the global impact. If you approve drug A and drug B, most often the patients aren't going to get the other expensive drugs like C and D. You're displacing some other therapies and saving money in other parts of their journey, so that is just not worked out well enough. The whole societal impact and the cost, the value equation is looked at differently. And our goalposts here for approval and funding tend to be even stricter perhaps than they ought to be. I remember the fellow that designed that term level 1 evidence. I think Sackett, right?
Sackett.
Yeah. So he actually retired in Owen Sound, close to my old partner. And we asked him to help us advocate and talk about these issues, because he actually said it in the beginning when I was a student years ago, you don't have to have level 1 evidence to change therapy. You should have level 1 evidence, but if you have level 2 evidence that's consistent across many clinical trials, matches up with biologic rationale of therapy and consensus in that field, that should also be enough to approve therapy as a close second, and that's kind of been forgotten about. The whole, evidence-based medicine concept that we have now in Canada, it's become so strict now, it's shackled us from rapidly adopting really tremendous innovations that are coming through that we're kind of being stuck behind. Evidence-based medicine is great if we have the processes to review the evidence and act on it quickly. If we're farting around for 2 years, the whole thing gets bust, and everyone gets kind of upset and disillusioned.
Okay. Thank you.
Thank you. There's two more questions from the floor, and then I'll hand it over to the respondents.
I just wanted to quickly say, is it because Europe is more open to doing trials faster than other countries, that they're getting the access to the medication? Like, I know that Canada, we do trials, but I know Europe does a lot of trials, and they're more open to having more trials done in Europe. Is that, could that be kind of in the mixture?
I don't think so. I think Canada's actually viewed very favorably by pharma and by international collaborators. In Europe, when they can't get people on the study and they can't get enough, they come to Canada, and we usually clean up shop and add patients on pretty quickly. So it boils down to the costs, I think, per patient of doing studies. The costs are cheaper now in Asia, Eastern Europe, for example. But in the Western countries, though, we're perceived as very effective trial groups, especially in oncology.
Hi, my name is Janet. I'm with a patient partner in arthritis. So thank you very much for the patient advocate. That's amazing work that you're doing and worth replicating everywhere. And also thank you for talking about all the complications of mental illness. Two things that have been a theme for me today is money. Those who are in this to make money, as very honestly John put it in the morning. They're in a business, they're here to make money. But also one of the biggest things is that when we see all of these different pockets of organizations, everyone is fighting for the same pool of money, for the same kind of funding. And that is sort of like the apple that everybody wants to bite. Bill Gates put money to find a solution for HIV/AIDS, and people had to come in not to fight over the money. So maybe we need to start thinking of a different model where money is not, that thing that everybody wants to fight for. The second theme is multisectorial, pluralistic, participation, patient-centered, right at the beginning. Because it's very important that while we're all here, and a lot of us are patients, we are here with a certain level of privilege as well. We have food, we have shelter, we have a job or some type of coverage, but a lot of folks who are in prison, for example, they cannot even come here, which is an awesome free conference, so thank you. And there's other people that precisely because of their diagnosis, they don't have a clear voice or a voice to bring it. So it is up to us, patients who are here today, to continue to look for that equitable piece, which is one of the 6 dimensions of care, quality care in Ontario. It has to be efficient, timely, patient-centered. It has to be equitable. And we need to keep fighting. And today, the contrast between cancer and all that requires it has, and the mental illness situation, also brought to my mind the fact that even us amongst patients are siloized. And we keep here pointing a finger, pharma siloized, and this group and that group. We are doing exactly the same thing. So the challenge will be to us to challenge ourselves and start learning and listening to each other and try to find where are we in common. And to me, the common thing is what I heard yesterday for the first time, that patient care path. Because no matter what disease you have, how difficult or costly it is, you want to be living well. You want to be living as well as you can. So I'm challenging ourselves to do something.
Thank you very much. Are there any responses or?
I would just say that we've been very successful in oncology when patient groups of different diseases, like different cancers, have collaborated together. The ClientCentered campaign working together, and for issues that are systemic, like the speed of drug approval, coordinating provincial efforts, it'd be great if psychiatry, rheumatology, the big groups, oncology, chronic disease could work together too. I think the power of our voices is, yeah.
I know I said 2 questions, but there was one that was snuck in, so I'll honor my commitment, and then we'll hand it over to the respondents.
I personally know the culprit, so I'll take it out on her. Brent Baker with the Canadian Pituitary Patient Network. And so I want to, it's an observation basically both for drugs, which are extraordinarily expensive on one hand, and the drugs that apply to the mental health field that may be pennies. And kind of layer that with an observation. I've had the opportunity to take out membership cards at 2 cancer clinics, and I was extraordinarily impressed with the environment that the patient enters into when you go if you're unfortunate enough to need to go in for cancer, as opposed to the environment that is generally the other types of patients experience. And so today, what I heard and I think might be really valuable is I just wondered, with respect to drug access facilitation, my first question would be, are you aware of anywhere else other than the oncology field where that kind of service is provided to patients directly? And I'm not talking about, the odd pharmacare or pharmaceutical type of patient support program, but just as a...
So it's most predominant in oncology. It's like you said, there's the most money in oncology. It's billions and billions of dollars a year. So they have the resources that other disease areas don't. So there are dozens of us in Ontario. There's a few dozen in the other provinces as well, so it's predominantly in oncology. I have a colleague who does partial oncology. She also assists with cystic fibrosis. So I know for sure there's at least, I believe that she works at St. Mike's, so it's a hybrid role because they don't do enough oncology for her to fill a whole day, so she also helps out with cystic fibrosis. I believe Toronto General also has a drug navigator who is not in oncology. I think that people are seeing the advantage of having someone take on these duties. It saves the physician's time and that saves money. It really helps patients. It keeps all of the drug access concerns centralized. Otherwise, you're going to go to different people who give different perspectives. So I think that I definitely see it could be in mental health as well. I'm not aware of that, but I feel that it could become more widespread. But it's very burgeoning, at least in oncology. This is actually the 10th year that we've even had drug navigators in oncology, so I would expect that it would come to other disease areas. It's just that, maybe it's like Sandy said, oncology kind of led the way, but it will be coming into other disease areas, I would expect, if we can find funding for it.
Yeah. Here, you just hold on a second. So I just wanted to say to Sandy that has that been explored as a potential option or solution to the people who leave with 6 days worth of 50 cents worth of drugs and have no way of accessing it beyond that?
Yeah, so in the absence of drug navigators, what we do at KMH, this role doesn't exist. So pharmacists take it on and social workers. And so sometimes we see who draws the short straw, because what ends up happening is we have the same amount of paperwork. So we also have new drugs that are expensive or drugs that aren't covered or drugs that, there's a number of reasons for that, but we use the Exceptional Access Program as well to get specialized funding, particularly for drugs actually in addiction medicine. There's some gaps there as well. So the problem is there's a ton of paperwork, and much of it could be standardized, but we end up picking it up because the physicians don't have time, and so it just takes time and it delays access and it delays discharges. The shelters are huge problems, and what we end up doing is we write letters to the Pharmacy and Therapeutics Committee and we make cases for patients that don't have access, and the hospital continues to supply it through our outpatient pharmacies at no cost to certain patients. But all of these are workarounds, and the problems with workarounds is that if you lose the person that started the workaround or the chart gets lost, the patient gets lost in the shuffle. And so although we do our best not to have those things happen, it's not as consistent or as effective as having, or efficient either, as having these folks play that role. And I think there is a place for it actually in psychiatry. It would look different than in oncology. Or in other diseases where you're using biologic drugs, but it can fit, and I think it can be designed. And you can actually use our patient advocate committees and our groups to also inform that and sort of what would be useful. But we have a long way to go in psychiatry on that, that path for sure.
I would just say I think the whole issue reflects that our healthcare system is a dinosaur. It was developed for inpatient care, doctors' fees, right? Initially with Medicare. And nowadays many of our illnesses are chronic diseases that need drugs. And drugs were never built into the system properly. We should not need navigation. You don't need navigation for radiation or for surgery, right? You come and have your operation. This is kind of an ill-fitting piece of the puzzle right now. I know being a journalist, I've spoken about that. They're looking at different solutions, but we're pretty broke, I think, as provinces. Our budgets are pretty broke. I like to think optimistically of how much money we could save by integrating, breaking down silos, threatening maybe some existing bureaucracies to revamp things a bit and have the courage to do that. But there are ways we could at least save money and improve things more quickly. And we really should not need when I mentioned the drug advocates to the previous Deputy Minister, Saad Rafi, when he was Deputy Minister of Health, he didn't even know we had this rule. He thought I was joking. He goes, you mean navigators to help book CAT scans and home cares? No. These are navigators. And he kept trying to change the topic. I said, look, our big problem is getting drugs paid for. I'm not changing the topic. We're not talking about home care and stuff. This is the challenge we're facing right now. 1/3 of my patients I see is either not getting the drug I would have chosen for my family, ideally, or not having access to that discussion, that option, because of funding.
But Alan, don't worry. If we solve a navigator problem, I promise you we'll find something else.
Thank you, Louise.
All right, and I'll invite Martina and Linda to give us the final word from the patient perspective.
I really don't have that much to add, as he took what I was going to say just now. We don't question the value of heart bypass surgery. We don't question the value of a total hip replacement. We don't question the value of seeing a family or seeing your physician. Why do we question the value of getting your medicine that you see the physician for in the first place? I guess I've never understood it. And as long as I've been around, it seems every time we break down one barrier, another one pops up. I mean, at the beginning we had CODA and CDR with no patient input. So we got patient input, then they come out with PCPA. So now we're trying to get some input into that. And then all of a sudden now PMPRB wants to get in on this health technology assessment. I mean, it's almost mind-boggling for patients to try to keep up with everything that's happening. It just changes as we meet. And, I think that at some point as Canadians, we've got to find a way to solve this problem. They've done it in other countries. Other countries use France and Sweden, and these countries, they have access to the medicines we need. Why is Canada struggling so hard with this? I don't know.
That's fantastic, Linda, because the segue to your comment is that yes, there was broken system and lack of collaboration, and patient voice was not being heard, but we've made a lot of progress since CODA, where we know now how to engage with agencies. We now know how to engage with politicians. We now know how to engage with different agencies. So we've got that experience that we need to harness and take with us to take it to the next level. And I'm very much encouraged by the conversations we've had at this conference. We've made some progress from last year. We've made some progress from, maybe 2-3 years ago, and I can see us growing exponentially in achieving our goals of making the Canadian healthcare system better, but including the patient's participation as collaborator into that change. I mean, I think as patient organizations, we're going to have to look at how we change our approach in one thing, and there's more than one thing, but the one I want to highlight here is think about it as a box of Smarties, where you've got all the different colors in the box. When you get a box of Smarties, you want to have all the colors in there, but you probably start eating the brown ones or the green ones or the red ones first, right? So think about it as you're going to get a box of Smarties. You're going to have less Smarties in there, but maybe you're going to have all the red ones, which are the ones you should be getting. And then when you need to get the next box of Smarties, will be all the blue ones or the green ones. So we're going to have to look at this sort of change in our healthcare system and how we get access to drugs from a value perspective, because what could be of value is not getting everything together at the same time, having all the options in your box of Smarties. So on that, I'm going to stop and turn it over to Sophie.
All right, thank you for that tasty analogy. So I want to finish by thanking our panelists for some really inspiring presentations. I also want to thank our patient panelists that have been providing some great insights throughout the summit. So let's give them all a hand. Thank you very much.